I'm Tsuyoshi Morito from Waseda University. Thank you for the opportunity to give a presentation. I have two latest papers. Let me briefly introduce each of these papers. This study was published in European Spine Journal. Okay, sacroiliac joint pain increase repositioning error during active straght raising. Okay. The active straght raising test, ASLR, is reported as a useful evaluation method for sacroiliac joint disorders. And the current ASLR test evaluates subjective difficulty during ASLR. It is considered necessary to have an evaluation that can be demonstrated with an objective numerical values. When we treated a patient with SIJP, he complained that I'm not sure about where my leg is. So when we lifted the lower limb as shown in the movie and asked him to raise the leg again with the same angle, a significant repositioning error was observed. So we set up this experiment to clarify this phenomenon. Okay, the purpose of this study is to compare the repositioning error of patient with unilateral SIJP group to that of patient with lower pain and a healthy control, and to investigate the difference between the symptomatic and asymptomatic sides of patient with SIJP group. SIJP group has 22 cases as shown here, and they were defined when they have pain around PSIS and at least 70% of pain relief by block injection to the posterior sacroiliac ligament. LBP group has 22 cases who have lower pain other than SIJP. Healthy control group has age and gender matched 22 healthy individuals. This is a method of the ASLR repositioning test used in this study. Definitive marker were placed on external ankle joint and greater trochanter. The participants were placed in a supine position with their eye closed. The examiner folded their heel with raised their lower limb about 45 degrees and asked, remember the angle. This angle defined as a base angle. And the examiner released his hand and the participants memorized the position of the lower limb and then returned to the floor by themselves and they ASLR in targeting the base angle. And the difference between the base angle and the ASLR angle was defined as repositioning errors. They repeated this measurement 3 times. Okay. If the repositioning error is larger than the base angle, it is indicated by plus. And if it is smaller, it is indicated by minus. Repositioning error was calculated by analyzing the image taken by the fixed camera from the side. The average of 3 times was calculated and divided by the left and right to obtain the representative value. We compared repositioning error among the groups and between the symptomatic and asymptomatic side in the SIJP group. Result: clinical characteristics of each group is shown here. Healthy control group have no symptoms, and there was no difference in the degree of NRS, ODI, and RMDQ among the 3 groups. The figure showed the result of repositioning errors. It was 3 degrees in the healthy group, 4 degrees in the LBP groups, and 8 degrees in the SIJP groups, and a significant difference was observed. In SIJP group, we compared repositioning errors between symptomatic and asymptomatic side, and we found that symptomatic side had significantly larger repositioning error than the asymptomatic side. Okay, it reported that the SIJ is divided into articular zone and a dorsal ligament zone, and about 80% of cases have pain originating at posterior ligament zones. In all patient present cases, pain relief was obtained by block injection in the posterior ligament area, suggesting that the posterior ligament was involved in the pain. It has been reported that there are no receptors around the posterior ligament area. So we think SIJ pain affects proprioception impairment, which is responsible for the repositioning errors. Limitation. Hip joint position sense was not evaluated, and this method can only be performed if lower limb elevation is possible. A conclusion. A patient with SIJP increased repositioning error during ASLR, which may be related to impaired proprioception. And the ASLR repositioning test may be useful in the evaluation of sacroiliac joint impairment. Then the next paper, contraction pattern of the lateral abdominal muscle during abdominal drawing maneuver. The lateral abdominal muscle of the trunk include the external and internal oblique muscle, EO and IO, and transverse abdominis muscle, TRA. The TRA attached to the transverse process of the lumbar spine via fascia, and its contraction provides functional stability of the lumbar spine. The left image is an echo image, and the right is a kinematic MRI image. Contraction of the TRA is thought to be effective in preventing lower pain. This is a pamphlet from a Japanese academic conference. It is a drawing. It has also been reported that the TRA contracts before as a lateral abdominal muscle, and that contracting it alone is effective in preventing low back pain, and is also associated with growing pain. Perhaps the TRA are intrinsic muscle of the pelvic ring, and we think that their activity before the extrinsic muscle is effective in stabilizing the pelvic ring. The detail of the muscle contraction during an isolated contraction of the TRA have not been clarified. So the purpose of this study was to determine the contraction pattern of the abdominal muscle during isolated contraction of TRA. The participants were 21 healthy adult males. Fine wire electrodes were applied to the TRA, and surface electrodes were applied to IO and EO. Before the experimental trial, two physical therapists instruct the participants in isolated contraction of the TRA while showing them the screen of the ultrasound imaging. We confirmed that the isolated contraction of the TRA could be performed on the ultrasound imaging. At the trial, the participant was asked to perform a slowly 5-second drawing maneuver. Okay. We analyzed the onset time of muscle activity for each muscle during a 5-second drawing maneuver. The horizontal axis is time. The analyzed section was from 1 second before to 4 seconds after the start of the drawing maneuver. The integrated profile method was used for onset analysis. Statistical analysis was performed by comparing the onset time of muscle activity for each muscle. Result. This is the onset time of muscle activity for each muscle during a 5-second draw-in. The EO, IO, TRA are shown from the top. The TRA initiated muscle activity significantly earlier than the other muscle. On the other hand, there was a difference only 1.1 seconds between the onset time of the TRA and that of the other muscle. In ASLR, it is important to act TRA earlier than pelvic extrinsic muscle, such as IO and EO, or rectus femoris muscle, to stabilize the pelvic ring during perturbation from elevated leg. And this TRA anticipatory contraction allows smooth lower limb elevation. If pelvic extrinsic muscle acts earlier than TRA, pelvic ring instability might occur and cause pain around SIJ. We thought instruction of the TRA anticipatory contraction might be a useful motor control exercise to patients with SIJP. Conclusion. When the drawing maneuver was performed over a 5-second period, the TRA was the fastest to initiate activity among the lateral abdominal muscle. Even with practice using ultrasound image, the isolated contraction of the TRL latest only a short time. Okay, that's all for my presentation. Thank you.
Thank you very much, Professor.